Assalamualaikum and hello everyone. Welcome back to our monthly Sinar Daily Life and Style podcast with me, Dr. Nurhamiza Zulkifli. And today we are in the month of October, and as you can see, all of us are wearing pink with a tinge of pink with a pink ribbon, that we are celebrating the month of breast cancer awareness. Breast cancer has long been the most common cancer among women in Malaysia and also worldwide. Statistically, based on the National Cancer Institute in Malaysia, it accounts for about 30% of all female cancer cases. Of course, it has topped amongst all of other cancers for the women. For today, we will be discussing on breast cancer in pregnant women in the early reproductive age groups, because as we can see, as the past decade, not just in breast cancer, in any cancer, the age of the population who are being diagnosed with cancer are becoming younger and younger. So if you talk about women, they are in the reproductive age group, and some of them are pregnant and when they are diagnosed with breast cancer. And this poses a very, very challenging in terms of their management. And also, we also would like to discuss in those who carry a genetic predisposition such as BRCA1 and BRCA2, which is BRCA, a breast cancer gene, which our panel will explain it in detail. So these situations raise not only complex medical management, surgical management, but also profound psychosocial and also emotional challenges. So to help us explore this important topic, I'm so honored to have two distinguished guests with me who are expert in this field. On my left hand most, I have Professor Aishah Taib. She is a senior consultant of breast surgeon from Universiti Malaya Medical Center, whose expertise in breast cancer management has been instrumental in advancing care in Malaysia. Welcome to the show, Prof.
Thank you.
And on my left-hand side, we have a male with us. So this is Mr. Jefferson Ng Kai Kiang. He is a clinical psychologist from Psychosocial Support Department from NCSM, National Cancer Society Malaysia in Kuala Lumpur, who has worked extensively with patients and families, providing psychosocial support and guidance through the cancer journey. Welcome to the show, both.
Thank you.
So today, we're not going to only discuss the statistics and also the management of breast cancer in these special groups, but we also would like to dive deeper into the psychosocial and also psychological impact and also support system that is equally vital. So without wasting any more time, let's just dive into the topic. All right, let's get started. So first and foremost, I have always started my discussion with my clinical expert. So first, we would like to understand the whole scenario of this special group of breast cancer patients. So, Prof. Aishah, many still think that breast cancer only affects elder women, 50 years and above. But increasingly, we see it in younger reproductive age group and even during pregnancy. So how is it different in terms of managing those patients who are in their reproductive age group and also when they are pregnant? How is it different compared to our typical patients who are already menopause or maybe they are more than 50 years old?
Okay, I think the first thing is that we have to recognize that the commonest age groups that get breast cancer is women in their 40s, 50s and 60s. So only about 2% of people in Malaysia who have breast cancer are less than 30 years old, 35 years old. But 40 years old, it comes up to about 28%. And the rest, 70% of them, will be in above 40 years old. So the young group is actually not that many, but the numbers are increasing. There was just a publication this year that looked at Southeast Asian countries, 11 countries, and it showed that the young group is actually increasing in terms of breast cancer incidence. So I think we have to be really aware about this. And you mentioned a few of the challenges because our country is a developing country, a developing nation. So there are a lot of socio-economic transformation, and therefore you can see that people are having their children later, right? And then people are having their periods earlier. So the risk factors for breast cancer is increasing in our as we speak. And this group of women will definitely have more risk of having pregnancies during breast cancer. So in terms of the management, I think when we talk about management, you look at the person as a whole person. It is not just the individual, but also the people around them. It could be the spouse, could be their even parents, because these are young women. So I think the difference, management-wise, not much difference, because we believe in age doesn't really change the management, the clinical management of the patient, but more so the biology of the tumor. So a lot of the treatments are based on what type of breast cancer the patient has. Okay, but in terms of handling a patient would mean that you need to also consider other issues, the values of the patient, especially if the decision maker is not her. It could be the parents, for example, or even the husbands. So when we counsel this type of patients, it's very important that we, as doctors, we recognize that they have other people that might be making the decisions. So when we talk to them, we have to make sure that they are present as well. Okay, so the treatment is actually quite the same with older age groups.
It's just that the people that surrounds them. So the in terms of the challenges would be, how do you want to convey, and the decision making might not be only her. You have to consider the rest of the people around her as well, right? Okay, so Jefferson, when patients are diagnosed at a younger age, from your experience, or during their such vulnerable stages of their life, right? Sometimes they are just about maybe started working, if they're 30, 35, because nowadays we can see, like Prof. Aishah mentioned, a lot of people nowadays, the women are starting their, I would say, family a bit later. I mean, we see more about 35 and above, they're still getting pregnant, more than 40, right? So sometimes the emotional impact also would be different. So from your perspective, how do younger patients process this diagnosis from your whatever you have encountered in NCSM as compared to the older ones? How is it different in terms of
If honestly speaking, providing care to the older patients is actually much more easier as compared to the younger patients, because when it comes to a younger patient, like even that 2% of breast cancer getting diagnosed earlier than 40 years old, there are more complexities to it, because below 40 years old, they just finish their school, they just go into workplace, they are still planning out their life, so many things to actually work on. But when the cancer hits them, they just their whole world just crumbles down. Everything changes. Their plan for their retirement, like Prof. Aishah just retired, then maybe she has been planning her retirement for so long. But a lot of patients, they have not reached that level yet. And then they have to think about, oh no, what's going to happen with cancer? What's going to happen? Will I have a healthy child when I got pregnant later on? Can I even get pregnant later on? So all these complexities just makes it more difficult to manage, but not to say that it can't be managed. It can be managed just with more things to worry about, things to concern about. Like how Prof. Aishah also mentioned, that it involves the whole of the patient. Right, the environment, who are these people that's involved with this patient itself. Therefore, there's a lot more things to cover as compared to the older patient. Because when older patients, they have a lot to achieve already, they may just, most of their fears are about fear of dying, or fear of dying with dignity. But for younger patients, there's a lot more to actually work on. So I would say it's very complex, but not to the point that it cannot be managed.
Right. So it's quite common for you to see people coming to NCSM under the psychology. I mean, to get some psychological support. Is it very much common here in Malaysia? I know in overseas it's yes.
Yeah. I think I'm very happy to see, over the years, right? There are more. There's an increased population that we can see actually approaching us to receive mental health support. Unlike the very first time when I was working with NCSM, right? It's very difficult to approach a client to mention that, hey, I can see that you are suffering. I can see you're in a lot of distress. Would you wish to speak to a counselor or to speak to a psychologist? The first thing they'll say that, no lah, I'm not okay. Crazy. I'm okay. I'm not crazy. No, I just have cancer. I'm not crazy. But now, as the trend moves forward, can we see that, hey, people are more acceptable to receive mental support. They have the awareness that mental support is part of their cancer care journey. And they are more readily to actually speak to us and to get that support from us.
I think because nowadays the awareness in terms of the mental health support and also the mental health awareness also have played such a big role. So I mean, they don't feel alone. And it's not you won't be judged if you actually come forward to seek medical attention.
Because last time everyone was just judging.
Yeah.
When they notice that you are seeing a psychiatrist or say psychologist, they'll say, you crazy ke?
Yeah.
You gila ke? But now it's like, oh, okay, I'm so proud of you.
Yeah.
You're actually approaching a psychologist to get support. So actually get empowerment from the community, knowing that the awareness is there.
Okay. All right. So, so we have touched in terms of the general, the hurdles that we are facing. So now we're going to go into the specific in terms of breast cancer in pregnancy. So moving on back to Prof. Aishah. So how common it is in your practice, and the statistic nationwide, breast cancer during pregnancy in Malaysia, and also when does this happen? Of course, there would be challenges in terms of, because now you are managing both pregnancy itself is not a disease, but when you are pregnant, you have all your physiological changes, and on top of it, if you are diagnosed with breast cancer, it adds on. It can be quite haphazard if it's not being managed accordingly. So what are the main challenges when you are managing patients with breast cancer in pregnancy, especially to manage between the fetal and also the maternal? Sometimes they are just worried whether can they continue with their pregnancy or should they terminate their pregnancy. How is it like?
Okay, so being pregnant and having breast cancer is not very common. Okay, so I think institutionally in our hospital, we probably see something like maybe 2 or 3 patients per year, with a patient about 300 patients per year. So maybe that's about 10%, yeah. But I think because we're an academic center, so we get referrals, right? But if you look at the worldwide figures, it's something like 1 in 3,000 pregnancies to 10,000 pregnancies. Okay, unfortunately, it's more commonly seen in the developing countries because our breast cancer patients are generally younger compared to the developed world. Okay, so the main challenges I would say is that the patient needs to do things within a stipulated period of time because the pregnancy does not wait and neither does the cancer. So there are many issues. One of it that we see is the difficulty in recognizing the cancer whilst being pregnant or even breastfeeding, even among the healthcare providers. So there are many situations where patients have delayed diagnosis because the nurses or the doctors that have been taking care of them during the pregnancy think that, a breast lump can be managed after the delivery, okay, which is not true. So any woman with a breast lump, especially even if they're pregnant, should be seen by preferably a breast surgeon or a general surgeon to have it diagnosed. Most likely it's just some lump that is quite benign because these are young women, but we must rule out a cancer. So what we do is a triple assessment, like for everybody, like some form of imaging and ultrasound. And usually we do not do a mammogram unnecessarily in pregnancy. But if let's say we know that clinically it is a cancer, we can shield. We can protect the fetus from the radiation for the mammogram, and we can still get that information from the mammogram. So the management, as you mentioned, it really depends on how far along is the pregnancy and what sort of treatments would be suitable at which stage of the pregnancy. So it is quite common that when I was a medical student or a medical officer, I remember these poor women coming in having termination of pregnancy. Okay, the doctors have actually advised the patients to terminate the pregnancy. But at the current moment, termination of pregnancy is not a must. It is not a treatment for breast cancer. So what we do is we have to calculate the gestation or the pregnancy, how far along it is, and what treatments would be suitable at which stage of the pregnancy. So in the first trimester, surgery is safe, okay, because surgery is done in the chest area. So it does not increase the risk of abortions. There may be a small risk of having the type of anesthesia that the patient gets that can cause some teratogenicity. But generally in the first trimester, surgery is actually a safe option. Okay. In the second trimester, that is like after 3 months or 4 months or so, okay, they can get chemotherapy. So in some situations, we do use chemotherapy before surgery, and we can use this chemotherapy. Usually it's about 5 times, so every 3 weeks. So generally the patient will go along with the pregnancy With, of course, I forgot to mention the biggest challenge actually is to make sure you have all the doctors you need in the same hospital. Because that is the key actually to a successful treatment during breast cancer in pregnancy. You need a multidisciplinary team because you don't only need the surgeon, the oncologist, the radiologist to manage the cancer. You also need the obstetrician, the gynecologist, the neonatologist to ensure that the pregnancy is done safely and the patient can deliver at the right time. So I would say the biggest challenge maybe for someone with breast cancer in pregnancy is to go to a place where it has everyone. So I would suggest an academic center. So we have Universiti Malaya Medical Center, UKM, as well as I think some of the bigger hospitals now, they have quite a big multidisciplinary team on board. So it's very important to seek out tertiary as well as quaternary specialist centers when you have this very challenging problem. Yeah.
Okay. Because sometimes they are worried. I mean, like Prof. Aishah mentioned, it's not the management is not to just terminate the pregnancy nowadays. Those probably the old, I would say, concept. I mean, because you probably want to save the mother, but nowadays it depends. It will be tailored accordingly based on the period of gestation of the pregnancy itself. So I mean, like Prof. Aishah mentioned, at second trimester, they are actually safe to. They have been administering chemotherapy drugs, and they would adjust the timing of delivery. Do they? Is it common to deliver and also surgery at the same time? I mean, is it common?
It could happen if the patient needs, let's say, a cesarean section. They could have the surgery together, but essentially, even the normal delivery is possible. So what usually happens is that the timing of chemotherapy, for example, they have to stop the chemotherapy so that there is time for the body to recover, the immune system to recover before they go for normal delivery. Yeah, so sometimes the delivery is planned. So it's something like they call it induction lah. They induce the delivery so that the timing is just right. Yeah.
So that's why it's very, very important to have, if anyone who's been diagnosed with breast cancer in pregnancy, it's very important, like Prof. Aishah mentioned, in an institution that you have all the support. I mean, so if anything at any point of time, then you have the neonatologist. If it's premature, then you have the obstetric and gynecologist to manage it accordingly, right?
And of course the social worker.
Yes.
Because as I think the psychosocial
and the guys
impact,
as well, not just social. Okay, and the doctors, guys also need to learn all these things.
Yeah, the guys definitely need to learn. Okay, so but really, I think the social worker plays a major role here because I mean, imagine you have breast cancer and you're pregnant.
Yeah.
So a lot of the women I've come across women who they want to protect the pregnancy. Maybe it's a precious pregnancy because usually these women may be in their late 30s or early 40s. So it's a very difficult decision. So they will need someone to support them. And access for psychosocial support is not easily available.
Exactly.
Yeah. But thank goodness the obstetric and gynecology team seem to have very dedicated social workers. Yeah. So that's a big resource actually during this
because I think they need all the resources they need. Sounds like a very complex situation when you're pregnancy and breast cancer. For me, it's just a whole new learning curve lah. For a guy and also a psychologist, everything's new to me.
So now we're going back to, since you mentioned regarding the, I mean, I would say the man, I mean the husband also has to be there throughout the whole journey because pregnancy itself is not easy. They will have their mood swings for the woman, for the pregnant ladies. At the same time, they have to manage about the cancer that they are facing and the chemotherapy itself, the side effects of the chemotherapies. So now we're going back to Jefferson since he's as a man and also as a psychologist in this picture. So psychologically, how do mothers to be cope with this facing cancer while carrying a child? That's number one. And then how do you as like the psychologist, I mean what you have in NCSM or maybe other centers which has all the psychological supports, helps support both the family and then the husband and the wife and also the patients itself competing with the emotions. Mainly, it's not just, I would say probably women, they are I would say they are made to be quite resilient, but the emotional stress, I think that those are the things that really can shatter inside. So how would you go about and comment about that?
Yeah, so I love that you mentioned that women are actually built to be resilient, which is, I agree so very much. It's very true. Yes, coming from a guy as well. Yeah, yeah. So this is where the part where you turn on the volume, especially to your husbands, to actually listen to how to actually help your wife to actually cope through it lah. So how to cope, right? It's, I believe, the very first thing that I can think of, it's to manage the emotions that's within you. For example, is there any fear that comes with, because from a person, from a guy, learning that whole complexity of it, it's very, very scary. You have to go through so many doctors, so many ologists, right? It sounds like extremely scary. So that is the very first thing that I will wish for everyone, the ladies or even the guys to actually help to address, which is the fear for women to have. Because cancer, when you talk about cancer, it's like, hey, cancer equals to death. And it's still in the whole community now, cancer equals to death. So there's a lot of fear going in, and the person has to come to terms with fear, right? When you say addressing fear, it's not to, take fear away, take it away, just throw it aside, or just sweep it under the rug. You can't do that, even if you can do that, but eventually it will still erupt itself. So what I always like to tell my clients is that come to terms with fear, make peace with fear, allow fear to be part of your world, and knowing that it can be contained, it can be controlled, where you can actually live with the fear itself. Because fear is an emotion, and emotions make us human, right? Imagine the whole world without fear. Yeah. What's going to happen? It's going to be chaotic in a bad way, I would say. So fear should be part of everything, because with fear, everything, it motivates people to do something. Right? When we're afraid of getting breast cancer, what we do? We go for screening, early detection. We're afraid of death because of cancer, then we'll go for treatment. So don't let fear be the barrier to reaching what your goal is, right? So allow fear to be there, make peace with fear. So for mothers it can be extremely fearful, to be afraid, how would this treatment affect your child? How would your child affect the treatment even? So like Prof Aishah said, learn to create your team of doctors, of ologists around your team, and learn to give more trust to them as well. At the same time, give trust to yourself, knowing that you are built to be resilient. And sorry, just now we also mentioned how to support the person, right? So for family members, at the same time, learn to understand that, hey, the person is going through a lot, right? A lot of times, right, when a person got diagnosed with cancer, what happens to the family? Everyone suddenly become a doctor, right? They say that, they become doctors, they become dietitians. They say, can you eat this, can you eat that? You need to go to this, see this doctor, right? You cannot do this, you cannot do that. So suddenly everyone wants to be part of it, right? So try to understand that, hey, the person is going through a lot of emotion, right? Don't add more information to make it more overwhelming, right? You can be supportive by just being there with the person, right? Only if the patient asks for more support. Let's say the patient asks, can you be there? Can you give me like a second opinion after whatever the doctors have said? Then only you give your second opinion. Don't be just act smart and then to give everything there. It's going to be very, very traumatizing for the patient. So your physical accompaniment, just sitting by them when you're feeling sad, when you're feeling fearful, give them a hug. All those is actually powerful enough. You have to trust that all these things are powerful enough to support the patient. Not words, not anything, just be there. It's actually very, very powerful already.
Yeah, sometimes they say just be silent, be by their side is more than enough. You just don't say anything. It's sometimes you just need someone to just be there, to listen, not to say anything, right?
Yes. And we have to be comfortable with silence as well. A lot of times, right, we're afraid of sitting there, not saying anything, would it cause my anxiety? Or you start to sweat a lot when you're being silent, right? Actually, silence is very, very powerful.
Okay, all right. So that's our point of view from a man and also from a psychologist. All right. So we're going to move on to our third part. I mean, in terms of, I would just ask a short question to Prof. Aishah in terms of the misconception, because we already talked about pregnancy. That is, if you're talking about person with pregnant ladies and then they are diagnosed with breast cancer. But sometimes some people, they have this misconception that or maybe husband will have the misconception that if the the women are in their reproductive age groups, if they're diagnosed with breast cancer, they have not had their child yet, so they can't get pregnant. So this is what we call in terms of breast cancer in the reproductive age group, and so will it affect the fertility? So moving on to into the next part, I would just want to ask Prof. Aishah in terms of what are the current strategies to preserve the fertility. Maybe you can elaborate more in terms of the misconception that you have encountered in your clinics and all regarding how the other, I would say the other spouse have been seeing if the woman is diagnosed at the younger age group, and in terms of the
I think it's a big is a variable response lah. You see from the partners, right? The husbands. So some are very supportive, which is really important. And some are completely have lost it, so they're more anxious than their wives.
It puts shame to guys, actually.
Okay, but honestly, I think I've encountered many supportive husbands. Okay, but I think the more important part when a woman, who's young, and usually you get this problem maybe in their 30s or early 40s, and some of them may not have had their children yet. So this idea that after breast cancer they will not be able to have any more children. There are actually research that shows that women who get pregnant after breast cancer actually live longer. Okay? Alright? So there are this type of what do you call it? Healthy mother effect, they call it. Okay? Of course, these are more like observational studies. No randomized control trials can be done there, right? But they have been shown that it is safe even for some groups of women with early breast cancer. They can actually stop their treatment. So for example, some of them may need to be on tamoxifen, right? For 5 years, but they are now 38, they want to get pregnant. If their cancer is a very early stage, they can talk to their oncologist to time it in such a way that they can stop the tamoxifen for a while, get pregnant. But all this need to be done under guidance from their oncologist, because those medications can also cause problems to the baby, right? Okay, so that part, being a mother after breast cancer is possible, right? Because I've met a man who actually asked this question. If the woman has had a mastectomy, can she have a child? Okay, so I mean the community may not have any idea at all. So I think if there are real questions like this, please ask. Because you will find that it's not true. Okay, so that's one of it. So when a woman is faced with getting a breast cancer at the age of maybe where the biological clock is ticking and all that, there's this thing called fertility preservation. So this is what we do with our colleagues from the gynecology fertility centres. So there are multiple. I think in UMMC we also have one, but there are many even in hospital Sultanah Aziza, I think in HKL they also have something like that in the public sector. So what happens, the most important is the speed of how we do things. So that is why when you are faced with this problem, go to a more specialized place. So either you could meet up with breast surgeons, especially in academic centres or in tertiary or quaternary centres where they have everything. Okay, because what can happen is that this communication between the doctor, the diagnostician is usually a surgeon, right, to talk to the gynae to say, oh, this lady is worried about her fertility. She's worried that she may not get pregnant after this. So can you please see her? Because you can actually do a lot of things before they start treatment that will affect their fertility. So what are the treatments that affect fertility? It's mainly chemotherapy. Okay, so usually what can be done is a referral, and they can induce the patient to be producing their eggs. Okay, or even freezing part of their ovaries. Okay, and then this procedure needs to take some time. So usually it takes only about 2 weeks, right? 2 weeks is enough actually, just to wait until you go on to your chemotherapy. So generally this has to be done very early after diagnosis, so that it can be quickly organized, so that the woman can safely preserve her fertility and have her treatments at the right time.
Right.
Yes.
Okay. Right.
Okay. So it is possible. But of course, women who are older, like above 45, generally after chemotherapy, they may actually go into menopause. Okay. But whether that menopause is permanent, usually you have to wait and see. But after 45, it's actually quite difficult lah to retain the fertility. That's right.
Even if it's not it's not cancer related, also 45, it's a bit difficult to get pregnant, isn't it?
Right.
In fact, I mean, when you talk about fertility preservation, even for men, for young men with cancer, they can go for sperm preservation. Kan, you can store the sperm or part of the testes and all that. And this has, I think the committee needs to know.
Right,
And they need to be empowered, so they will ask. Because if let's say you go into a very busy public hospital, you're 38, nobody is going to tell you about fertility preservation and you don't know anything about it. Okay, so I think it is available, but access would be a problem because this type of care is actually very expensive. So they call this artificial ART, artificial reproductive
Treatment.
innovation, something like that. Oh no, treatment, maybe therapy, ART. Sorry, I'm not a gynecologist. So anyway, that thing costs money. So you need to store. Imagine if you got to store your eggs or your part of your ovary or testes or sperm, and you got to pay every year for the storage. It's be stored in a very perfect place, with the right temperature and everything. So it is quite a costly thing. Even inducing the eggs and all that might. It might cost something like 10,000.
Oh wow!
Yeah, it is quite costly. So if you have even in the private sector, I think even in our hospital, it is still quite expensive.
Right.
So it's some sort of like I think we had our session before this in June where we talk about the TTC journey. I mean to all our listeners out there, you can actually look up our YouTube where we do actually talk about preservation, the embryo preservation for those who are married, or if those who are not married, they can actually preserve their eggs. So they would undergo what Prof. Aishah mentioned, the assisted reproductive treatment where they would induce ovulation and then they would extract what we call the oocyte pickup, and then they would keep the eggs, and then when the time is suitable, it's some sort of like an in vitro fertilization at the end of the day. But of course, the best thing, like Prof. Aishah mentioned, is to go to what we call the onco-fertility. They are the onco-fertility. They are much more expert in this, and they would advise accordingly. So to all the medical practitioners out there, if you happen to see a patient which is younger age group and they are being diagnosed with breast cancer and they have not completed their family yet, these are the questions that we should ask. Sometimes they already have few children, but they still want more, and they are about maybe 32, 33. So these are the questions that I would say is mandatory, it's compulsory to be asked. And because nowadays we have advanced in a lot of stages, so we have the facilities, and it's our job to actually offer to them, and it's their options for them to take. Right?
And for the guys out there, there's still hope, okay? So just don't terminate a pregnancy or stop pregnancy because of the fear now.
And then don't have that misconception like what Prof. Aishah said, because there are men who are very, very supportive. And also, I would say maybe the other some men, I don't think so that they are not supportive. Maybe they don't really understand the whole scenario. But the doctors, the medical professionals, they are always open for any questions. Don't worry, none of the questions are stupid questions. You can just ask and we would answer to it. Right, Prof. Aishah?
Yes.
Okay, so coming back to Jefferson, on your side, how do you address the psychosocial challenges around identity? Because sometimes when Prof. Aishah mentioned regarding the fertility treatment, but how about in terms of the body image? Because sometimes they are young and then they have to go mastectomy, they have to remove their breasts. Part of sometimes you have to do breast conserving. That one is still okay, they can do reconstruction. But those who have to remove entirely half of their breasts on the whichever side, then that they may have the psychosocial body image, distortion. So how have you seen in your practice?
Yeah, when you're asking this question, I have this one client that just pops out of my head, because the first thing that she asked me when I met her was that, does it make me less of a woman when I have gone through mastectomy? And that question hurt me so much. It hurt me because it's like, hey, what makes you a woman is not because you have breasts. Maybe biologically, yes, but even you have removed part of your breast or both of your breasts, it doesn't make you less of a woman, right? Because how you identify yourself, all those years living as a woman itself would help you to identify yourself as a woman, right? So, and I keep on thinking what would actually contributed to this question from this client. I can imagine that the client's background, family support may not be there, and then to make her feel so fearful, to be less of a woman because she has to go through mastectomy. And so that is the problem that we face sometimes in the community where they're still very fearful of what's going to happen to them, their identity. I understand that when you got diagnosed with cancer, your role would have changed. I mean, previously you are a mom, you are able to breastfeed, but then now you can't. So it's just going to be challenging, but it doesn't mean that you are less of an identity that you already preserved and created for so long. So in order to work through that, it's to help them to remind that, hey, what have you gone through? Help them to rediscover themselves again. If they wish to change their identity, because maybe previously they were a mom and then now it's a cancer patient, or previously is a caregiver and then now they have to take on the role as a patient. So all these are changes that we have to just adjust and make peace with, come to terms with the adjustment. So it doesn't mean that even you have been forced to go through all these processes, it makes you less of a person you are. You're still the same you, just that, hey, maybe physically you are different, but you're still you. I know I have knew you for so long. Doesn't mean that because you've gone through some procedure then you are different now. So patients have to actually understand as well.
Okay, that's a very good point. I also want to ask in terms of we are talking about the body image. How about in terms of it has an effect in terms of their probably marital status? In terms of we can see sometimes. I mean, I wouldn't say all, but sometimes they do have. Their spouses who probably left them because got to know when they have cancer. But when you actually need the support from the other half, but instead they probably decided to let the wife go through the journey alone.
Yep.
I mean, could you just share a little bit on that?
Right. I think this is such an important question to ask because just before this recording, we were just bashing about how guys actually were leaving, and then I'm the one in the middle. They actually put me in the spotlight. So I just, as a guy, I actually want to actually make this a message across to all guys out there, right? So as much as you are fearful of what your wife or your partner is going through, understand that they are fearful as well, And imagine if they are fearful and then because you are fearful and then you abandon them, they are the one who has to go through that. For guys, not say us, for guys, some guys who just wash their hand clean then when they leave that, but they are the one who have to go through that. So maybe the guy is actually going through a lot of fear as well, so they should take on the task to manage those emotions within them. So abandonment is never the solution, but resolving it together as a team. You have made your vows when you are married together, right? So uphold to that vow as much as how scary the whole process is. It's going to be extremely scary, but it doesn't mean that you couldn't go through that. As much as how doctors say women are built as resilient, I believe men can be resilient as well. Maybe they're not built, but they're created with resilience. So understand that, abandonment is not. It shouldn't be an option. It's never a solution to the fear that a patient is going through.
Do you think that for men and women in that situation, they need someone to help them communicate?
Definitely, because if both are in a state of fear, right, their communication may just be very emotionally driven, right? It may not be rationally driven. So that's where I shamelessly come in to mention that a psychologist or a counselor or a marriage counselor can be the bridge between these two fearful islands. They are isolated and then they need someone to actually bridge them out together. Maybe they are so fearful. We talk about attachment styles. Some are avoiding, some are very needy. Maybe the woman is actually avoiding because they are afraid of giving burden, right, to others. And then the guy is actually wanting to address that. So all these are just differences that we have to address. So a person who is objective enough and an external party able to bridge them all together.
So basically the most important point is, I think, complementing each other as like a husband or wife, and then or even family members. It's about complementing and also supporting. I think that is very, very important. And there is it's okay for us to be fear about it and to be you have that fear, the thoughts, but it's not the end of the world. We have, like Prof Aishah has mentioned, we have advanced so far in Malaysia itself. most of them we can manage. Just go to any tertiary, quaternary hospitals. They would able to solve the problem. I think, however complicated itself. I mean, I graduated from UM, and I know I have seen how Prof Aishah counsel the patient. I mean, we have seen very, very super complicated cases, and alhamdulillah, we managed to manage it as long as I think it's being tailored accordingly, and the patient and the family itself wants it to be to the issue to be resolved. So we are here to support everyone and all the patients out there. Yeah. Okay, so since we talk about mastectomy, and then I'm sure everybody knows who Angelina Jolie is, where she has this what we call BRCA genes, this genetic predisposition. So actually, maybe Prof Aishah could enlighten us. What is actually BRCA? I'm not so sure how it is. Like, maybe Prof Aishah can share the level of how Malaysians have perceived this genetic testing in Malaysia, but maybe you could share with us what is BRCA mutation and how significant BRCA mutation is in our local context. Maybe you can share some of the data and the management per se in terms of this BRCA gene mutation.
So I think when we start talking about genetics, everybody like tak nak tahu dan because it's too scary or too complicated, right? So I think the first thing you must know is that this is something that is additional information available to us, because I think a lot of families, you'd be surprised, even people with strong family history, they know that they have this strong family history, they also do not do anything about it because they have a very fatalistic view of it, say, oh, if I get it, I get it, but actually there's so many things you can do to either prevent it or even to reduce the stage of the cancer, so that you can get treated, you can get cured. Okay, so what is BRCA? So BRCA is a gene that actually helps to control the growth of the cells. Okay, but in some people, this gene is slightly changed, so it doesn't have its normal function. So you can imagine our body, we have like billions of cells. So when you were born, you actually have this change already in this gene. So therefore, you have this higher predisposition to getting cancer. So we talked earlier that 1 in 23 women in Malaysia would be at risk of breast cancer in their lifetime. But if you have, like say, about 10 women with BRCA1, 6 of them will actually get cancer in their lifetime. So that's about a 60% overall lifetime risk. Okay, so it means that your risk is almost like how many times more? So our general population is about 5%. These people, their risk is like 60%. So that's many fold increase in breast cancer. Okay. So this type of change in the genes can be inherited. So what happens is that if you remember biology in secondary school, right? So you remember that some of the genes can be inherited in different ways, right? So this gene is inherited through the autosomal dominant method. So what it means is just that when the mom is pregnant, the chance of actually transmitting down the gene is about 50%. So not every time like she gets pregnant, the baby will have the gene. But it also doesn't mean that if you have 10 children, 5 of them will have it. It's like every time you're pregnant, the chance of transmitting is there.
Right.
So when we talk about BRCA gene, it was discovered in the 90s. And it is, the test has become cheaper and faster. I mean, you can get the test within 2 weeks, you can get the results. Okay? And it's available. The cost is something like 1,800 ringgit now in Malaysia. And this type of test, usually we don't just do 2 genes anymore because the technology has made it cheaper to actually do a whole panel of genes. So there are many types of cancer gene panels that is available. So some have 47 genes, but we know that for breast cancer, predisposition genes, there are about 20 over of them. So when the patient, it's not like we can do this test for everybody. Because number one, who's going to pay for it, right? Because the risk of breast cancer in Malaysia is only 5%. It's not like 65%. So we have to find the people that might actually carry this gene. So how do we do that? We go through a list of criteria. So the criteria would mean that this family might have a high risk. So it could be like 3 family members. And when we say family members, it's in the same line of family. So the mother side or the father side. So actually both sides can transmit the gene. So that's the other myth that people, all these things, it comes from the mom side. No, the dad side, so you can get it lah. Okay. So if you look at the criteria, so if you have 3 family members, first or second degree relatives who have breast cancer or ovarian cancer, so they would be someone that we would offer the test. Okay. Or if there's a person with breast cancer who have this thing called the triple negative breast cancer. So at any age, if they have triple negative breast cancer, we can offer this test. Alright? Or there are people who have bilateral breast cancers or ovarian cancer history within the same person, then yes, we can offer the test. So the reason why we have this criteria is to make it cost effective. So with this criteria, if 10 people went for a test, one person will have a positive gene test. Okay? So that process of giving all this very complicated information is called genetic counselling. So genetic counselling is usually done by a genetic counsellor. So that again is a big access issue, but it has improved because now we have a local university that actually runs a course that actually credentials these genetic counsellors. So it's in UKM. And we have about, I think, if I'm not mistaken, close to maybe 20 or maybe less. I can't remember, but they're not that many. But what we did in Universiti Malaya, we worked very closely with Cancer Research Malaysia. I think the whole project started in 2003, okay, long time ago. So we have experience with counselling, genetic counselling. And when you do genetic counselling, it's not only on people who have cancer. Once we found the result in a cancer patient, then we will have to contact the relatives, right? So in Malaysia, we don't contact the families directly, okay? It will depend on the person who did the test.
Okay? Based on the patient itself.
The patient themselves will have to contact their family members. So this is again a big barrier.
Right.
Okay, like in Australia, for example, you might actually get a letter in the mail that says a family member have had a genetic positive result. Please come over to this genetic clinic or something like that. Okay,
Right.
because but they don't disclose who is the person who did the test, but it's a family member. Okay, but in Malaysia we can't do that lah. Okay, PDPA and many other ethical legal issues, right? So the family members who would be probably the best person to receive this information because they haven't had cancer. They can do many things to prevent their cancer. May not get the test done because the information doesn't get to them. Because a lot of women that have been tested and they found to be positive, they don't like to share with their family members. They feel like they're the bearer of bad news. You know, like they don't want to, make it difficult for the family. So sometimes it's very difficult. We have had families who never disclose to their relatives, and then they keep seeing one sister after the other coming in with breast cancer, and some of them have some regret. But I would say, I think with the current generation where people are more, maybe a bit more scientific or straightforward, they probably use it as a information that can add on some information. So okay lah, I'll tell my family. But in the past, there's so much cultural, like if you tell your family, in some ethnic groups, it might be detrimental to their marriageability of their children.
It's going to cause a lot of chaos in the family.
Yeah, so the family the children may not get married because when they do the matchmaking, got family history, got gene, you cannot lah. So yes,
taboo, that kind of
the
thing.
taboo is there. So all this have caused a lot of barriers. But actually, the person who would benefit the most is someone like Angelina Jolie. She didn't have breast cancer, neither did she have ovarian cancer, but her mom and her aunt had cancer. And the reason why she did it, I think in her op-ed, she said it's her kids, right? She wants to see them grow up, right? So she did it. And what she did was a prevention method through surgery, where she had the breast removed, double mastectomy and a reconstruction. and then she had the removal of the ovaries later on. So she is like a story that can be shared and people can understand. So we are grateful that, you know, she was willing to share it with the world, right? So but I think a lot of times in Malaysia we do have risk management clinics. The uptake for oophorectomy is actually better than mastectomy. But I have to say, over the last few years, last time our uptake for prophylactic mastectomy is only like maybe 15%. But in the recent times, it has probably gone up to about 50%. Okay, the oophorectomy is still not that high. The ones that go for it are people who are menopausal, because they're very scared when they prophylactically remove their ovaries, they become menopausal. But unfortunately, for ovarian cancer, there is no way to detect it early. No way at all. No test or imaging or anything would detect the ovarian cancer early. So it is almost like, you know, the oophorectomy will improve their survival rates. Okay, it's very complex, because even someone with the gene doesn't necessarily mean that they will get the cancer. So the risk is not 100%. So as mentioned just now, right, BRCA1, the risk is like 60% lifetime risk. So the other 40%, but who knows which side you're going to be on, right? So the way we counsel patients on risk management really will have to take into consideration a lot of things, because this is a normal person with no disease. So we have had a lot of mishaps in the past where doctors are not really well trained to do this part of the counselling for risk management. So once they have the disease, oh, you have to do all this. So they get double mastectomy, and the woman becomes, you know, depressed. They really, and this is there's no disease here. Okay, so the way we talk about is a reduction in risk rather than treatments. Okay, so a lot of women take a long time to decide. Some of them take. I have had a patient 10 years now. She's had the ovaries removed, but it took her 10 years. You know.
Wow, I think it took a lot of courage for her to
exactly.
make that decision also. Right, 10 years.
Yeah.
So it just sounds like that is like a double-edged sword thingy. You know, whether you go for it, then you can get treated earlier. But if you don't go for it, you are still living in that fear.
Exactly.
All right. So that's an important point. Like I mentioned, like Prof. Aishah has mentioned, that Angelina Jolie, I mean, do not be afraid. She doesn't look like less of a woman at all. I mean, if you can still see her Instagram, she's still
she's still Angelina Jolie.
Yeah, she's still Angelina Jolie.
True.
So don't be worried. And then that's a very brave step that she has taken. And I'm sure a lot of women in Malaysia also, like in I think Prof. Aishah's clinic, the BRCA clinic, they have also underwent the same surgery as well, mastectomy as well, also so oophorectomy, where they remove their ovaries, and they can live like a normal lifestyle. I mean, they shouldn't be affecting who you are, because I think the who you are is actually inside you. It's not what is manifest by your physical appearance only. Okay, so we have talked about this BRCA, and some patients, if they have actually undergone mastectomy, removal of their breast, or those patients who are diagnosed with BRCA, but I mean has the genetic BRCA, but they have not developed cancer, like Prof. Aishah said, 60-40%. You know, the psychological weight can be a bit heavy. So I mean, you're worried whether you will get, you will not get. I mean, I have removed this kind of things. You know,
it's like a ticking time bomb. You don't know when is it gonna explode.
All right. So how do you help patients manage this kind of living with risk? I mean, like it's fear, like you said, you have to accept, try to make peace with it. But how would you, I mean, manage it in
I think
patients?
It's always, when it comes to like BRCA, right, and all this, you know, taking time bomb thing, you know, waiting for it to happen. It may or may not happen, right? So there's always this anticipatory grief, you know, because when it comes to cancer, there's everything is just starting from grief, because you're loss of your previous health, loss of your chances, loss of your time, right, and loss of many things, many chances in a world. So it's always this anticipatory grief. You know, you don't know whether it's gonna get it or not. And so going through this process of managing this grief itself, it's one of the ways to actually help it, right? And also another way is to make, again, I'll keep on using the word make peace, because it makes so much sense, because making peace,
accept it,
right? Acceptance. Yes, I was just about to say acceptance, right? Accept that your life is being very unfortunate. You have BRCA, you know, you have been flagged with that gene itself, right? You can't change it. we haven't reached that point of technology where you can change a gene lah, right? We can only change our genes, right? Not that specific gene, yeah. So before we actually reach that advancement, we just have to make the acceptance towards that. Hey, you got with this gene itself, right? You can't change anything. This is outside of your locus of control, right? You can control things, but this is just, unfortunately, is not one of it. So what you can do is, hey, let's just change our perceptions towards this living with this BRCA itself. Rather than seeing BRCA is always, it's a ticking time bomb. I don't know when it's gonna happen. Rather than focusing on that, what if you see another way? Hey, my life has a ticking time bomb. Would it help me to actually appreciate life better? Knowing that I don't know when the cancer will come, it makes me realize that my days are numbered. By using the remaining days of being numbered, hey, let's do something meaningful out of it. I can see a lot.
Your life to the fullest.
Yes, exactly. I can see a lot of people who are just mindlessly doing things because maybe they pretend they are still delusional, not going for the screen itself, right? So when a person actually got to know all this information and they know that they are at risk, they would actually be more open to appreciate life itself. And that's what I always advocate for my clients as well. Even though you have cancer, very unfortunate, let's do something about it. Let's make your life more meaningful. What are your values? What do you wish to do last time? Maybe last time you're just working, you have no time for yourself. Hey, maybe this is a signal for you to actually pay more attention to yourself. Again, seeing these as signals. They are not, they're not a judgment call.
Yep.
Right? They are not your death sentence. They are signals to tell that, hey, you have something more to your life that you are missing out. Use this as opportunities to actually explore on these things even better.
I mean, I've seen patients who, the thought of having double mastectomy is massive, especially if you don't have any problems. You're young, right? You got a lot of other issues. But once they've had it, that relief is visible. It's visible.
Yep,
you can see that they're less, they're not so anxious.
It gives them hope in a way, right? It gives them hope that, one thing is out of the way already. So again, it's not that scary to I mean, it can be, it is definitely also, scary.
I mean, we mustn't forget there are a lot of support survivors out there who have gone through it. And there is a support group. You can actually contact Breast Cancer Welfare Association, and also you guys have the young person, the Pink Unity. There are many support groups around.
Exactly.
And there are people who have lived through it, and they are actually having a better life now.
Exactly.
Much more, right? I mean, you've seen the survivors, right?
Yeah. So they are much more happier than all of us. All of us are just honestly. working, and for them it's just happier.
They keep on going on holidays.
Yeah, exactly. They learn how to live life more than us.
So like Prof Aishah and Jefferson has mentioned, there's a lot of support groups out there for regardless for those who are pregnant ladies who are diagnosed with breast cancer, the special groups that we have mentioned, or the young breast cancer patients, or even those with having their genetic predisposition with BRCA1 or BRCA2. The support is there. It is there's a handful of support group. We will probably share it on our Instagram when we post on our YouTube. So of course we would like to go deeper and more in terms of the innovative and all the other challenges. But of course, time is always jealous of us. So before we wrap up this session, maybe I'll let Prof and Jefferson to give their insight. A key message to the young woman who may feel that they are too young to worry about breast cancer, because like what we have mentioned, of course it's about 2% only those who are diagnosed in the younger age group, but the numbers are increasing. So maybe Prof can just add on the take-home message, whatever. I mean, not just for the too young or anything for this breast cancer awareness in terms of get yourself screened early, mammogram, those things. I mean, Prof Aishah can start the ball rolling first.
All right. I think for young women, and when we say young, maybe less than 40 lah, kan? Okay. So young women, when you have a lump, it is likely not to be a cancer. But unfortunately, you need to know what it is. So actually, the race, the time that you need to sort it out we know now in the WHO guidelines is 60 days. You need to diagnose a breast symptom within 60 days. Because remember this age group, we don't do screening. There is no screening for women less than 40 because screening also has harms. So I would like to tell all the young women out there, do not do indiscriminatory ultrasounds. Because we have had many women in their 20s, they just, okay, I'm so healthy, I'm so health conscious. I want to do screening. So what happens? People are offering ultrasound screens for anyone, right? And guess what happens to these poor young ladies? They have their scans done. They have been found to have some benign cysts. Then what happens next? They cannot get insured. Okay, so I think this is a very important message for young women. Do not do unnecessary scans because those benign lesions may not cause you any harm at all. But what it may cause you is that you will not be able to get insurance. Okay, so we have had women coming every year to be, we have to write letters to say, this is a benign finding. It doesn't mean that this is going to have a higher risk of breast cancer. But no, this is predisposition. Cannot. So a lot of our insurance companies do not cover these women for breast cancer. So please don't do that ultrasound if you don't need to. Okay. But if you have symptoms and you have risk factors, so risk factors meaning you must know your family history, right? If you have any of these things that put you at higher risk, then you should see someone to do screenings. And those screenings are really very, very tailored to the type of family history or to the genetic mutation that they have. Okay, and where do you get these services? I think you have to look for breast surgeons, okay, or gynae oncologists. They may also be part of this. And I forgot to mention BRCA1. It used to be called the hereditary breast and ovarian cancer syndrome. But now they've added another cancer to it, which is pancreatic cancer. So the predisposition for pancreatic cancer is also there. Okay, but then pancreatic cancer is a very deep-seated organ, and removing the pancreas is a very, very morbid. The morbidity is very high. So a lot of problems can happen from this very major operation, right? So we only screen pancreatic cancer screening in the BRCA carriers if they have a family history of pancreatic cancer. Okay. Alright, so remember, don't do ultrasound unnecessarily. But if you have symptoms, you got risk factors, please go and see someone so that you can be put on a screening program.
Right.
Okay.
So more is not always good lah.
Yes.
So maybe Jefferson would add on in terms of the psychological support, emotional support.
So okay. I mean, after today, right, we have discussed so many, and there are so many big words that's even to me lah. Yeah. So I think a lot of young women out there will be very fearful, very scared. Not knowing what is the best thing to do. Whether to go for this, to go for that, or whether should I go for this. Just now we were talking about BRCA, and now Prof just said not to do so much. I think they're a little confused lah. Yeah. But I think in the end is that always learn to be confident in your team, or even learn to be confident with yourself, knowing that which is actually the needed one. And then learn to gather information like our podcast today, right? Learn to gather those accurate information. Accurate, not to just go for ChatGPT. Just go for accurate one, right? And even go to your doctors if you're unsure. Get those things, necessary things done, and also understand that hope is always there. Regardless of whether you're being diagnosed, you're not diagnosed, you have risk, or your husband very unfortunately abandoned you, always know that hope will forever be there, right? Regardless of what has happened, and hope will be the driving force to a better life, improve life, or to your own life. It's not being driven by anyone. It's your life because that's your hope, and therefore live the life feeling with hope rather than feeling with fear. I mean, it can be fear, but understand that hope is always there.
All right, thank you so much. Okay, for the lovely insight. So, as basically just to wrap up all the discussions that we have mentioned, the key points in terms of breast cancer in pregnancy, it's not very much common, but it can be. It would be such a. I mean, it's not very easy to manage. Make sure that you have the multidisciplinary approach, and then if you are young breast cancer, don't worry. It will not affect. I mean, it can affect your fertility, but there are methods for us to preserve the fertility treatment. Just you have to go to the right center, any tertiary or quaternary centers, find the right person, not ChatGPT, not Google.com. So basically, you can just Google to find which is the place or the hospital that you could go, but they don't have the 100% answer. You have to find the medical expert.
Yep.
And also in terms of BRCA genes, BRCA1 and 2, so they have this genetic screening. I think it's been offered in the universities level. Just have to find which university and where, and please don't be shy and spread the awareness. Like Prof. Aishah mentioned, usually here in Malaysia, we will not send the email to the rest of the family members. You yourself have to inform your family members. So please do share with them, because it's your responsibility. I mean, you need to save other people's life as well. So it's your responsibility. You need to share the information with other people. And for the psychological part, psychosocial, emotional support is very important. Family, spouses, I mean, you have to be there. I mean, please do not abandon anyone with cancer, because they themselves are going through it, and it's not easy for them. And imagine the stress that you would put on them if you just walk away from the problem. All right, thank you so much, Prof. Aishah and Jefferson, for sharing your expertise and also your insights with us today. I think our listeners will agree that this session today has been an eye-opening discussion, not just about the medical aspects, the technical aspects, and for breast cancer in special groups, we have also touched about the psychological, emotional journey that patients and families go through, and where they can actually find their support and also their comfort. So all our audience, don't forget to follow all Sinar Daily social media platforms, and also download Sinar Daily's new and improved mobile application. So remember, breast cancer is not just a fight against a disease. It's a journey that requires medical care, emotional strength, and also community support. If you or someone you know is affected, please reach out for help from anywhere. I mean, you can DM on Instagram. You can find on the website to go and find any hospitals, any breast surgeons, any psychologists, who can actually give you the social counselling and also emotional counselling. You are not alone. So until next time, take care, and let's continue to spread the awareness and also hope. Take care. Assalamualaikum. Bye.